All right, welcome back to the Critical Care Shock Lecture Series. More specifically, welcome back to Part 2 of our Volume Resuscitation Series. In this session, we're going to focus specifically on fluid responsiveness. Before moving forward, let's do some housekeeping, disclosures and disclaimers. I have no relationship with industry. I have no financial conflict. With that said, just a quick point to be made. I obviously avoid discussing specific brand technologies due to the risk of bias, but I'm also avoiding them because it's been my experience it's very easy to slip down a lecture rabbit hole with this. My goal is to give a precise educational building block, then you can go research the specific technologies yourself. So let's take a look at what we have on the menu to discuss today. Obviously, fluid responsiveness. With that, we're going to go over a definition. We'll discuss briefly about clinical exam. We'll go into the fluid challenge, passive leg raise test, and we're going to talk about the heart-lung interaction a considerable amount. With that, to be more specific, we're going to go over arterial waveform analyses. We'll also review IVC variation. Now, considering the majority of the folks listening to this webinar do not do TEE, I'm going to leave out SVC variation for this webinar. We'll also go over aortic flow velocity variations, tidal volume challenge, and the end expiratory occlusion test. And last but not least, we'll sprinkle in a bit of qualitative transthoracic echo. To simplify the purpose of this topic, we're really asking ourselves if we should give fluids. And when doing so, we really should be asking three questions. Is the patient hyperperfused and/or in shock? Is the patient fluid responsive? And is the patient fluid tolerant? Today, we're going to focus on the first two questions. So the first question, is the patient hyperperfused and/or in shock? And why is it important to ask this question? Well, to start with, the human heart is generally fluid responsive. I'm quite certain that I'm fluid responsive right now. This doesn't mean that you should give me fluids. I'm not hyperperfused. I'm not in shock. The next question, is the patient fluid responsive? And if we recall from our previous volume part 1 lecture, the only goal of giving volume is to increase stroke and cardiac output when we're dealing with shock. But how do we determine this? We need to understand if the patient is fluid responsive. If they're not, there's no indication to give further fluid. In fact, we may be hurting the patient. We may be causing harm by administering fluid to a non-fluid responsive patient. In regards to question 3, is the patient fluid tolerant? We'll be discussing this in a separate lecture, volume part 3. Without further ado, what's the definition of fluid responsiveness? Well, historically, the definition has had a wide variation, but the current up-to-date definition is a 10% or greater increase in stroke volume following a fluid challenge. Looking at the summary of historic data, you'll see that there's a wide variation when it comes to the topic. There's a variation in the type of fluid used to conduct the fluid challenge. There's a variation in how much volume was given, at what speed, and as previously stated, there is a variation in the definition of response. It's interesting to see the amount of responders found in the historic papers. I'll do the math for you. The average here is about 54%. Now, if we take the outliers with some unreasonable definitions of volume responsiveness, that gets us to 49%. That's saying that historically speaking, only about 50% of your patients are going to be fluid responsive. Now let's talk about how we can assess for fluid responsiveness, and I'll start with clinical exam. Now, when I say clinical exam, I mean the physical exam and various vital signs. I'll make this short and sweet. The clinician's accuracy of predicting cardiac output, let alone fluid responsiveness based on the clinical exam, is about 50%. In addition, there's poor inter-observer agreement. Now don't get me wrong, we don't ditch clinical exam. The clinical exam increases the likelihood for determining the volume status, but it's only part of the puzzle. An extreme example of this would be an elderly woman that's nauseous, vomiting, having diarrhea, poor PO intake, still taking her furosemide, and she has poor skin turgor. This clinical exam increases the likelihood for her to be volume responsive. However, as we know, not all patients are this simple to manage. We need additional tools and data to make the important decision of volume administration. So I won't mince words here. If you're solely using clinical exam to assess volume status, you aren't delivering optimal care. Another area of discussion would be static hemodynamic parameters to predict fluid responsiveness. And while there's others out there, the main two would be the central venous pressure, also known as the right atrial pressure, and then the pulmonary artery occlusion pressure. Now, in a perfect world, the central venous pressure is a preload marker for the right ventricle. In an even more perfect world, the pulmonary occlusion pressure is a preload marker for the left ventricle. But as we've learned in previous shock lectures, static preload measures do a very poor job in predicting fluid responsiveness. To simplify the rationale of this finding, we need to remember that pressure does not equal volume. That is, a pressure that you transduce in a cardiac chamber does not equate to its volume. In addition, we need to be reminded that there's a multitude of variables that go into preload other than volume status. This includes valvular function, heart rate, inotropy/contractility of the ventricle and atrium, as well as the ventricular compliance. It's worthwhile to take a look at some quick data summarizing the topic. Dr. Merrick and his colleague in 2013 published a meta-analysis labeled "Does the Central Venous Pressure Predict Fluid Responsiveness?" An updated meta-analysis and a plea for some common sense. In this meta-analysis, they found that using a CVP in the ICU to guide fluid resuscitation has an area under the curve of 0.56. Let's just slow this down for one bit. The area under the curve is a discriminator of a result being a true positive versus a false positive. Anything less than 0.5 for area under the curve is just chance. As you can surmise, an area under the curve of 0.56 is barely any better. This meta-analysis is the root creation of the mantra-like teaching saying that using a CVP to predict fluid responsiveness has the diagnostic accuracy of flipping a coin. Even in papers that the clinician preemptively was aware of what the stroke volume measurement was, CVP and pulmonary occlusion pressure performed very poorly for predicting fluid responsiveness, with a positive predictive value of 61% and 69% respectively. With that said, we prefer a dynamic hemodynamic parameter as opposed to a static hemodynamic parameter when trying to predict fluid responsiveness. So the most raw dynamic variable to look at in regards to fluid responsiveness is the fluid challenge. A fluid challenge test is conducted by measuring a baseline stroke volume or cardiac output, giving a fluid bolus, and then checking a post-intervention stroke volume and/or cardiac output. So if there is an increase by 10% or greater in the stroke volume and/or cardiac output, the patient's deemed to be a fluid responder. Now, this sounds great at first, very simple. However, remember, only about 50% of your patients are going to be fluid responsive. So 50% of the patients you helped, you increased their stroke volume. But we also need to remember that up to 50% of patients you didn't help. Maybe you possibly even hurt them because, as we reviewed in previous shock series modules, overzealous fluid administration can lead to worsening outcomes. But not to digress, a fluid challenge, why are we doing it? We're trying to understand if fluid administration will be beneficial. There are some discussion topics that I would like to cover. First, a fluid challenge is a fluid bolus under very rigid controlled conditions. And really the whole time you're evaluating the hemodynamic response, and if you see no benefit from giving this fluid, you don't see an increase in stroke volume and/or cardiac output, you should immediately stop administering fluids. As a side note, this is another reason that my personal practice is to avoid maintenance IV fluids when I'm treating a patient in shock. Rather, I bolus, I fluid challenge in order to closely observe its effects. While the fluid challenge is closely observed, it is a method that gives some risk to harm. Because as I stated previously, up to 50% of the patients that you give this fluid to might not need it, may harm the patient. And lastly, another discussion topic regarding a fluid challenge is how much volume do you actually bolus the patient? What's your personal preference? 250, a half liter, a liter, 2 liters? I'd like to really discuss this in further detail in the upcoming slides. So the concept of fluid challenge for purposes of understanding fluid responsiveness was discussed way back in 1979. While a lot has changed since then, the general construct still exists. That includes the TROL objectives. T for type of fluid, R for rate of fluid challenge, O for objective, or better set, parameter that you're trending, and then lastly, L for limits. Let's look at T, or the type of fluid. In Volume Part 1 lecture, we concluded that crystalloids is the go-to. However, I will say that there are some small trials, small protocols that call for colloids being administered over 1 minute. However, as a generalization, crystalloids are your go-to fluid for fluid challenges. Next would be R, or rate of fluid challenge. And really within this question, you're asking two questions in of itself. How much fluid am I giving for the fluid challenge, and how fast I'm giving it? As far as how much fluid I'm giving, it's a balancing act. You don't want to give too little fluid in which there wouldn't be a response in a patient that would otherwise respond, but you also don't want to give too much fluid because in that case, you might be increasing your risk of harm. When it comes to how much fluid to fluid challenge, the definition really lacks consensus. There's really no standardization. However, with the help of some more recent literature that's cited in this slide, we conclude that we at least need 4 mLs per kilo for a fluid challenge. Knowing this newer literature has changed my practice. I used to be one of those give a liter of fluid and see what happens kind of guy. Now I'm more conservative, only giving a 500 ml bolus for my fluid challenges. So now how about the question about how fast to give this fluid? And at the end of the day, the answer is the faster, the better. As a generalization, I think if you ask many folks, they would say give it over a half hour, give it over an hour. However, there's multiple variables that can be affected just in that time length. Examples would be positioning or vasomotor tone or fluid redistribution, leak or loss. These would change our hemodynamics in our fluid challenge post-test. What's even more interesting, newer literature shows us that the effect of the fluid challenge fades within 5 to 10 minutes. So if you're doing this fluid challenge over 60 minutes, you might not be getting your bang for the buck when you're looking at your post-intervention stroke volume or cardiac output. So in conclusion here, how long should your fluid challenge last? How long should it take to administer? And the answer is between 10 to 20 minutes. Next, let's take a look at the O, the objective. Better said, what's the parameter that we're tracking? Now, this has obviously changed multiple times throughout the years, but for this discussion, we're going to talk about cardiac output or stroke volume. If your patient's cardiac output or stroke volume increases by 10% or more after a fluid challenge, they're deemed a fluid responder. And how do we check this? So we can evaluate this with a pulmonary artery catheter. I would not put a PA catheter in just for this situation. However, if you have a PA catheter in, you can use this testing methodology. If you don't have a PA catheter, you can look at the non-invasive or minimally invasive cardiac output machines out there. And you also can obtain some of these parameters via echocardiography. In transthoracic echocardiography, you would take the left ventricular outflow cross-sectional area and you'd multiply it by the aortic left ventricular outflow tract velocity timing integral. In addition, you could just take a look at the aortic VTI pre and post intervention, and if you see a change, an increase at 10% or greater, that patient too would deem to be a fluid responder. And lastly, let's take a look at the L, or the limit. Now, if we merge the 1979 literature into current day, we'd be talking about a newer concept, fluid tolerance. We'll discuss this in great detail in our volume part 3 lecture. The next dynamic test to discuss is the passive leg raise test. Before discussing the passive leg raise in detail, I'd like to go through the process in which to conduct the test itself. First, to start, spoiler alert, we're given a transient blood fluid bolus from the legs to the thorax of the body. Before conducting this test, make sure if the patient has compression stockings on their legs to take them off. If they have sequential compression devices, shut them off. And if they're a lower extremity amputee, the test is probably not going to be effective. So first, we want to start the patient in a semi-recumbent position. That's the back flat on the bed and the head of the bed at 45 degrees. Allegedly, this mobilizes the venous blood from the splenic circulation. At this point, we want to do a pre-test stroke volume and cardiac output. You can obtain that stroke volume or cardiac output from a minimally invasive, a non-invasive device, or even echo-derived. Historically, I would say that a PA catheter with a continuous cardiac output machine would not be able to keep up on this. However, the newer up-to-date technology for continuous cardiac output has a much quicker turnaround time, so it may be a possibility. Next, we want to take the head of bed down flat to 0 degrees, and we want to elevate the legs to 45 degrees. And this should be done passively. That is, the bed should be doing this activity for you. Unfortunately, I've never worked in a facility that has a bed with this technology. I've had to do this manually by essentially doing bilateral leg raises for the patient with my arms. The worry with this is that you can provoke sympathetic stimulation due to pain or anxiety or just being startled, so you really got to take this into context. You should have those legs up there from anywhere between 30 to 90 seconds. At this point, perform another stroke volume cardiac output test. From there, bring the patient back in their baseline position. That's head of bed at 45-degree angle and the legs flat. Now, if the patient was a responder, at this point, you want to repeat the stroke volume and cardiac output to ensure that the parameter returned to the previous baseline. And you're doing this to ensure that you had an increase in cardiac output due to the transient fluid bolus and not because there was sympathetic stimulation from fear or startling or pain. From there, if the patient was a fluid responder by means of passive leg raise testing, you would go ahead and give your volume resuscitation and you would start the process over once again to understand if they needed further fluid. Now let's take a little bit further detail into this test. You're essentially doing an auto transfusion, taking the blood from the legs, elevating the legs, transfusing that blood into the main thorax. So essentially, this mimics a fluid challenge, but the cool thing is it's reversible. So the downsides of a normal fluid challenge is that some folks, about half of them, won't be responders, but you can't get that fluid back. In a passive leg raise test, you can, so it avoids the risk of fluid overload. What's really great about this test, you're going to learn shortly, heart-lung interactions carry with them many limitations to the applicability of certain tests. However, the passive leg raise is not dependent on the heart-lung interaction, which is great. Now, the things that I do want to point out here is that the bed really should be doing the work. And if I'm guessing, your facility does not have one of these elusive beds that do a passive leg raise themselves. So you really have to take this into context. The next thing is interabdominal hypertension. Interabdominal hypertension is definitely an unrecognized issue, especially in the medical ICU. Some experts actually advocate to do an interabdominal pressure before doing a passive leg raise testing so you can ensure its accuracy. Some other limitations to point out: if the patient's severely hypovolemic, I'm talking hemorrhaging, when you do that passive leg raise test, there might not be enough blood volume in the legs to give you a response. And then lastly, anything that causes really high right heart pressure is an obstructive process. So right heart failure, maybe the patient has high PEEP levels, or they have a cardiac tamponade or a tension pneumothorax. This is going to affect a passive leg raise test. You can quickly eliminate these processes and limitations by doing a point of care ultrasound prior to doing a passive leg raise testing. Minus these few limitations, the test is amazingly accurate. A positive response is defined by a stroke volume or cardiac output increase delta, a change of 10%. And if you're doing an echo-derived stroke volume or looking at a VTI, your delta, your increase of 10 to 12% is deemed to be a positive fluid responder. With that said, the sensitivity is 86% and the area under the operator curve is 0.95. Those are excellent numbers, but this is only when we're talking about stroke volume and cardiac output. If we use pulse pressure variation, which we'll describe what that is very shortly, your diagnostic accuracy drops considerably. If you just use arterial blood pressure changes, the accuracy is even lower. So in closing, passive leg raise testing is an excellent test. It has very few limitations, and when using stroke volume and cardiac output, it has excellent accuracy. Now let's move on to the heart-lung interaction test. In these tests, we're either observing or manipulating what we know about the heart-lung interaction. We covered the heart-lung interaction in great detail in previous shock lectures. However, I'd like to give a quick recap before moving forward. As we remember, when a patient's on positive pressure ventilation, venous return is reduced and RV afterload is increased. This results in a reduced RV stroke volume. The net effect of this is a reduced LV stroke volume and cardiac output. We're able to see this finding on arterial waveform. The most blatant example of this is pulsus paradoxus. Interestingly, you see a lag or a delay of this effect on arterial tracing by about 2 to 3 heartbeats in relation to the arterial waveform variability and the respiratory cycle. And this is normal physiology. It's just exacerbated by many conditions, one of them being hypovolemia. Arterial waveform analysis is somewhat of a novelty of itself when it comes to hemodynamic monitoring. You have pulse pressure variation, and remember, pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. So what you see here is the monitor measuring the difference between the pulse pressure max and the pulse pressure minimum. Next is stroke volume variation. And stroke volume variation is a bit different. And this is a machine measuring the stroke volume. Whether non-invasive or minimally invasive, this is a cardiac output stroke volume measuring machine that actually measures stroke volume. As you can see here, the machine is taking the stroke volume max, the stroke volume minimum, and the stroke volume mean, and it's determining the stroke volume variation. And lastly is the systolic pressure variation. And as you can see, the monitor is taking the systolic pressure max and the systolic pressure minimum, and it's giving us a variability. So I feel as though the systolic pressure variation is what we see most grossly qualitative when we look at the monitor. I feel like this is what our eyes go to when we see pulsus paradoxus. But surprisingly, systolic pressure variation carries the lowest sensitivity of these three tests. The last thing that I like to point out is the same variability that we see on a pulse ox. This is the Pleth Variability Index. And while its use has already been incorporated into mainstream use, its validity is somewhat in question. It seems most accurate in an OR setting. This obviously limits our use and reliability of this test at bedside. Speaking of accuracy, third place goes to stroke pressure variation. Second place goes to stroke volume variation with a sensitivity of 0.82 and an area under the curve of 0.84. And then lastly, the winner goes to pulse pressure variation with a sensitivity of 0.89 and an area under the curve of 0.94. It's less prone to performance issues. It's a calculation, not a machine-based measurement. And best of all, less equipment's needed in comparison to stroke volume variation. Let's take a bit closer look at the stroke volume variation and pulse pressure variation. First, let's take a look at stroke volume variation. Again, stroke volume variation is a machine measurement by a minimally invasive machine. As you can see here, stroke volume variation is derived from the stroke volume max minus the stroke volume minimum divided by the stroke volume mean. Again, don't worry about remembering this formula. The machine is doing it for you. If your patient has a stroke volume variation of 12% or greater, they're a fluid responder. Next, let's take a closer look at pulse pressure variation. And again, as a reminder, pulse pressure equals the systolic blood pressure minus the diastolic blood pressure. And pulse pressure variation is the determinant of the pulse pressure max minus the pulse pressure minimum divided by the pulse pressure mean. Again, your monitor does this for you, but in some limited resource situations, you might have to actually know this formula to determine your pulse pressure variation. More about this very shortly. If your patient has a pulse pressure variation of 12% or greater, they're a fluid responder. Pulse pressure variation can be measured by numerous ways. One is a minimally invasive device, as I pointed out before. Another is hemodynamic monitoring software. So this is software that is most likely found on your hemodynamic bedside monitor. And lastly, you can manually measure and calculate a pulse pressure variation by freezing the frame of your arterial waveform, printing out a strip, and doing the measurement and calculation manually. Here's an example of doing just that. I've gone up to my hemodynamic monitor. I've changed the speed of my arterial waveform down to 6.25 millimeters per second. I then froze my frame. I've recorded the maximum systolic pressure, the minimum systolic pressure, the maximum diastolic pressure, and the minimum diastolic pressure. Instead of doing this calculation by hand, I use a leading brand medical phone app, and this allows me to determine pulse pressure variation at bedside. So we could do this, or we could make the monitor actually do its job. Our bedside monitors can be set up to show real-time pulse pressure variation on the monitoring screen. Just to recap arterial wave use and the discussion of fluid responsiveness, let's take a look at this Frank-Starling curve. If I have significant pulse pressure variation, I'm still on the steep end of the curve in which fluid can augment my stroke volume. So overall, we have a very accurate test, and it's quite easy to use. But, there's always a but, there's limitations. Unfortunately, all heart-lung interaction hemodynamics can only be applied to a strict subgroup. In fact, there's a good amount of contraindications to using these tests. The contraindications using these tests can be remembered with the acronym of R limits. R is for RV failure, L is for low heart rate to respiratory ratio, I is irregular heartbeats, like atrial fibrillation. M is mechanical ventilation with low tidal volume. So I want to pause here for 1 minute. What's low tidal volume? And in this situation, it's defined by a tidal volume of less than 8 mLs per kilo of predicted body weight, which is essentially what we run all of our ICU patients on. So this is a huge contraindication. Stay tuned though, I might have a way around this. I is for increased interabdominal pressure. T is for the thorax open, that's an open chest in the cardiothoracic world. And lastly is spontaneous breathing. This really needs to be emphasized. A patient that's spontaneously breathing or actively participating on mechanical ventilation carries a contraindication to these hemodynamic measurements. Let's explore this tidal volume limitation a bit further. In regards to pulse pressure variation, if you have a tidal volume greater than 8 mLs per kilo, you have a great test. However, as you can see, if you drop the tidal volume to 6 mLs per kilo or less, you lose the discrimination, the accuracy of the test. So the big question, is there a way to navigate around this? And yes, there is. It's called the tidal volume challenge. Let me walk you through how this test works. Here you can see that our monitor is displaying pulse pressure variation. At 6 mLs per kilo of predicted body weight for a tidal volume, you can see that the pulse pressure variation is 8. This is less than 12%. So here it's saying your patient is not a fluid responder. This could possibly be a false negative due to the low tidal volume. So what do? Well, you increase the tidal volume transiently for 1 minute to 8 mLs per kilo of predicted body weight. Here you see a pulse pressure variation of 15. 15 is greater than 12. This patient is a fluid responder. From there, you decrease the tidal volume back down to baseline, 6 mLs per kilo of predicted body weight, and you see the pulse pressure variation go back down to 8. So to recap, what you've essentially done is uncovered a false negative by increasing the tidal volume up to 8 mLs per kilo predicted body weight. How about the accuracy of this test? So first you can see if the pulse pressure variation on 8 mLs per kilo of predicted body weight tidal volume hits a threshold of approximately 12% or higher, you have a sensitivity of 75% and a positive predictive value of 100 to predict fluid responsiveness, so quite accurate. However, we can do better. What seems even more important is the differences between these two provoked tests. That is the pulse pressure variation of 8 and the pulse pressure variation of 15. The difference is 7. So what we see here, if you have a change from your tidal volume from 6 mLs to 8 mLs, and you have a cutoff value greater than 3.5, you can increase the sensitivity to 94% with a positive predictive value of 100%. In this example, you see that the patient easily met this threshold, has a 7% difference, which is greater than the 3.5. This patient is a fluid responder. Now, while we've circumvented the limitation of the tidal volume, we need to remember all the other limitations. I personally feel that the spontaneous breathing or patients that are assisting ventilation is really a barrier here. So this might work with our deeply sedated patient or a patient that has no respiratory drive. Another pretty interesting test is the end expiratory occlusion test. So the way that you conduct this test is to perform a 10-second end expiratory hold on a ventilated patient. Obviously, the big limitation is a patient that can't tolerate that or won't allow it. And essentially, by doing an end expiratory hold, you're stopping the positive pressure ventilation. So the authors offer a meticulous description of how the test works. By interrupting the impediment to venous return induced by each mechanical insufflation, the expiratory hold allows the cardiac preload to augment, which in case of preload responsiveness leads to a significant increase in cardiac output. So what's the increase in cardiac output that you're looking for? You're looking for a delta, you're looking for a change, increase in cardiac output by 5%. If you see this, the patient is a fluid responder. So 5% is a pretty narrow margin, so we have to be cognizant of this. In addition, you really need a fast-performing, non-invasive or minimally invasive cardiac output machine to conduct this test. I do want to point out you also can use pulse pressure variation with a threshold of greater than 5%. This just reduces the sensitivity of the test just a tad less than cardiac output. And just one more thing to add about this test. There's a signal in the meta-analysis that we might be able to get away with a lower tidal volume that's less than 7 mLs per kilo of predicted body weight for this test. For providers that are echo trained, we can also look at the aortic flow velocity variations. It would only make sense that if we see these respirophasic changes in the arterial waveform, we would see it in the aortic VTI as well. Briefly, you capture the aortic VTI in an anterior 5-chamber view. Aortic stenosis is a relative contraindication to doing this test. Essentially, you freeze the image, you find the largest VTI, and you trace and measure it. Then you do the same with the smallest VTI. I'll point out right here that the VTIs both are less than 18. Anything less than 18 is abnormal and indicates a low stroke volume. From there, you calculate the difference between these two measures, the difference or the variation. Anything greater than 12% is positive for fluid responsiveness. And here you can see the aortic VTI variation is 33%. This exceeds 12%. The patient is a fluid responder. You can simplify this a bit by just measuring the aortic peak velocity. You can see in this image the sweep is decreased, so you can see a few respiratory cycles. You're going to freeze the screen and then drop a caliber on the smallest peak velocity. Then you're going to do the same for the maximum peak velocity. You're going to do the math and come up with the difference or the variation. Again, anything greater than 12% is positive. In this patient, they have a peak velocity variation of 21%. They're a fluid responder. Speaking of echo, let's move on to the infamous IVC variation. So what are the pros of doing IVC or IVC variation? Better said, why does everybody like it and keep doing it? So first of all, it takes very little training. Hop on YouTube and do a handful of proctored exams. My sarcasm is actually backed by literature. Generally, it's probably the easiest window view to obtain. This would be the subxiphoid or subcostal window. And next, it seems to be the ingrained holy grail of fluid responsiveness. You hear it all the time. Check an IVC. What's the IVC look like? And then lastly, it's inclusive to a binary decision-making model. The person's dry, the person's not dry. Well, this seems to be a pro. I actually see it as a con. Let me explain a bit more in some future slides. First, let's go over the cons of IVC. And while there's numerous ones, it's important that we do cover them. So first, some folks are just not able to see the IVC, whether it's bowel gas, whether it's surgery, whether it's abdominal tenderness or obesity or body habitus. Literature tells us about 1 out of every 5 patients we will not be able to see the IVC. Unfortunately, worldwide, we just don't know where to exactly measure the IVC. In addition, we really need to make sure that we're perpendicular, we're on axis when reviewing the IVC, or our imaging may suffer. We could have IVC fallout or foreshortening. These are echo, these are ultrasound words, indicating that the structure that you're trying to view is falling out of the window due to movement. In this case, respiratory variation, where the diaphragm is elevating, and on your ultrasound image, this may fool you into IVC variation. A very common issue is misidentifying the IVC versus the aorta. Literature tells us that there's significant interrater variability in assessing the IVC with ultrasound. And with that variability in interthoracic pressures as well as intra-abdominal pressures will affect the IVC. Respiratory effort will affect the IVC, whether the patient is very strong negative inspiratory efforts versus very shallow or weak breathing. Spontaneous breathing at all is a limitation to IVC. Let's put a pause in this discussion for 1 second. If there's a debate whether IVC is valuable, let's take a person that's spontaneously breathing completely off that discussion plate. And as with all heart-lung interactions, we need to worry about the low tidal volume issue. And then in addition, anything that would increase our right heart pressures. So maybe this could just be right heart failure, maybe it could be tamponade, PE, and so forth, can increase the size of the IVC itself. So as you can see, very few pros, many cons. I'd like to digress for 1 slide. Up until this point, we've been talking about dynamic measures. I want to talk about a specific static measure of IVC measurement, and that would be IVC end expiration. This is static measurement of the IVC at end expiration. So with this, roughly about 1 out of 5 patients could not be viewed. Up to a third of the patients had elevated interabdominal pressure, which is known to affect their IVC. And this paper did a great job with their breakdown, but if you look at the extremes of the measurement, so if an IVC end expiration was less than 1 centimeter, normally we would say, wow, that person's dry. But that only carried with it a positive predictive value of about 65% for fluid responsiveness. This should shock you. Let's go in the polar opposite. What if you have a big, fat, dilated, plethoric IVC? So if you have an IVC end expiratory size of 2.5 centimeters or greater, it only carries with it a positive predictive value for non-fluid responsiveness in 69% of the patients, with a negative predictive value of 42%. This is bad. So the authors themselves say there's moderate feasibility in actually getting the IVC view, but it poorly predicts fluid responsiveness, with interabdominal pressure acting as a confounding factor. So while they mentioned that it could add some value to guiding therapy, it shouldn't be used alone. And I think that's a great lesson, a great statement from the authors. It's also important to point out that all the patients included in the study were mechanically ventilated. So here's some examples of IVC measurements. As we know, we find the IVC in B mode, and then we switch to M mode. A simple explanation of M mode is a slice of ultrasound over time. First, we would freeze the image. And as we're resorting back to talking about dynamic measures, we're going to look at 2 different measurements of the IVC. We're going to look at one at end expiration and the other at end inspiration, and both of these are in mechanical ventilated patients. And while there's a multitude of formulas out there, currently we center around the distensibility index or the delta IVC. I would say that folks that actually do this formula anymore go to the distensibility index because it's easier to calculate. As you can see, a distensibility index greater than 18% is predictive for fluid responsiveness. I'd like to step aside and wager that the majority of folks listening to this lecture that prefer IVC don't even do this measurement, that they eyeball it. They do a qualitative assessment of this. For the purposes of this discussion, we're going to focus on quantitatively, that is actually doing this formula and coming up with these exact numbers. What's the big question? Is IVC variation in a mechanically ventilated patient reliable? So what does the literature say? First, before moving forward, it's important to point out that IVC literature has a high degree of heterogeneity. That is, there's different everything. There's different ways to measure, different formulas. Is the patient ventilated? Are they non-ventilated? What are the comparators to the IVC? That too in itself has a high degree of variability in some of the studies. The first meta-analysis I point out here, the author's conclusion is that IVC diameter has limited ability to predict fluid responsiveness. The next meta-analysis here, the author's conclusion are the distensibility IVC variation performed moderately well in predicting fluid responsive patients with circulatory shock and mechanical ventilation. In the stats world, moderately isn't the best word. The next meta-analysis, the authors concluded that the IVC respiratory variation is again moderately accurate in predicting fluid responsiveness. Another meta-analysis in 2018 then says a delta IVC shows limited ability for predicting fluid responsiveness. It goes on to say that patients with mechanical ventilation, tidal volume greater than 8 mLs per kilo, and a PEEP less than 5, IVC is an accurate predictor. Let's just stop the presses for a minute. None of our patients have tidal volumes greater than 8 mLs per kilo or a PEEP less than 5. So more reasonable, when we take a look at a real patient, a tidal volume less than 8 and a PEEP greater than 5, IVC was a poor predictor. And then lastly, this very detailed meta-analysis highlights the extreme heterogeneity of all the studies included, but then it goes on to say that ultrasound evaluation of the diameter of the IVC and its respiratory variations does not seem to be a reliable method to predict fluid responsiveness. So how do we wrap up this chat about IVC? Well, my very conservative response to that is that IVC is better than nothing, but when you can, use it with other measures and assessment so you can increase your sensitivity to fluid responsiveness. So as we wrap up our talk about heart-lung interactions in regard to fluid responsiveness, again, I want to remind you we need to know our limits. RV failure, low heart rate respiratory ratio, irregular heartbeats, mechanical ventilation with low tidal volume, increased abdominal pressure, open chest, and spontaneous breathing. And this applies to pulse pressure variation, stroke volume variation, systolic pressure variation, tidal volume challenge, and expiratory occlusion test, SVC variation, as well as IVC variation. So to close up this talk, let's include a little qualitative transthoracic echo interpretation and how that can assist you in determining fluid responsiveness. The image to the left, you can see a good peristinal short access. The image to the upper right, you can see a good subcostal window. And the image in the middle here, you can see our IVC and get a qualitative look at maybe some IVC variation. I'll first point out here the LV, the left ventricles. In both of these windows, you can see that the papillary muscles in the ventricle walls are actually kissing themselves. This is a hyperdynamic left ventricle, and it gives a perception of a low left ventricular end diastolic volume or area. Also to note is the RV. So in the parasternal short in the left upper image, you barely can see it. In the subcalcal image, you can see that it is hypercontractile and is not dilated. And then lastly, in the IVC window, you can see that you have a grossly small IVC, and what volume is in the IVC seems to be variable in relation to respiratory pattern. These images are a good example of looking at the IVC, but also comparing it to the other echo windows to support your diagnosis of hypovolemia. So in the setting of appropriate history and clinical exam, if I see these echo findings, I do feel the patient is most likely fluid responsive. Now let's take a look at a situation that you should not administer volume. The upper left window is a parasternal short access, and the upper right window is a four-anterior chamber view, and in the middle again is another image of the IVC. Taking a look at the left upper window, the parasternal short access, you might initially feel that the left ventricle is hyperdynamic. Well, it is, but there's other things to point out in this image. First of all, the septum is flattening. That LV almost looks like a D. And if you take a look at the RV, which is the orange star, it's massive. So whether this is pressure or volume overload, it's pushing into the interventricular septum. How does this clinically relate? This affects the right to left blood flow and also the ejection of the left ventricle because of the compression, not able to be eject. So i.e. this drops the left ventricular stroke volume. We take a look over the image to the right, which is the fore anterior chamber. The yellow star is the LV. The orange star is the RV. The RV should never be bigger than the LV. The apex in this window is formed by the RV. That is also a bad thing. And now we take a look at the IVC itself. This finding is what we would refer to as a plethoric IVC, a grossly dilated IVC. Chances are, given the appropriate history and clinical exam, these echo findings tell you not only not to give fluid, but that you might harm the patient by giving fluid. The last half hour has really been packed jam full of information and findings and variable numbers. I have this cheat sheet listed here. You either can pause and take a snapshot of the image, or you can give an email, and I'm happy to email it to you. But this is a quick cheat sheet, tells you all the hemodynamic parameters we went over, shows the cutoff value, and also gives you some nice notes and limitations. So wrapping this lecture up here, we've obviously discussed fluid responsiveness. We've defined it as a stroke volume or cardiac output that increases by 10% by either a fluid challenge or one of these heart-lung tests. We know that clinical exam alone is not sufficient to predict fluid responsiveness. We discussed at exhaustion about arterial waveform analysis, one of our passive leg waves testing, and we also talked a little about echo findings. What I really want to push forward here is people to understand that no test is perfect, at least yet. We need to use our clinical assessment along with the technology that we have to ascertain whether the patient's fluid responsive. Thank you for joining me for this session on fluid responsiveness. Please feel free to email with any questions. Thank you.